Hey, party people, welcome to tonight's webinar. We'll get started here in, we'll say 1 minute, promptly at 7:02. And to my fellow panelists, when someone else is talking, just mute yourself and then that way it won't pick up. Perfect. All right, shall we get started? Yeah, can I get a raise the roof? Something?
Yes.
Awesome. Hey, folks, welcome to tonight's SMSNA webinar. Thank you all for hopping on. My goal for tonight is to make sure that we stay on time. We will keep this to 1 hour. If we end a little bit early, totally fine. I don't think we're going to end early, though. I think we have a lot to talk about tonight. We're going to talk about the optimal integration of the advanced practice provider in a sexual medicine clinic, from hiring to excelling. I have some incredible people on our panel tonight. And just to briefly introduce myself, my name is Amy Perlman. I'm a urologist. I specialize in men's health, sexual health, and transgender care. I am in the great state of Iowa at the University of Iowa, and welcome to tonight's webinar. Helen, take it.
Hi, I'm Helen Burney, and I am an assistant professor of urology and the director of men's health at Indiana University. I'm so excited to talk to you guys tonight. We have so much fun stuff.
Awesome. Christy.
Hi, I'm Christy Martis. I'm a nurse practitioner. I currently work at Indiana University Health Urology Group alongside Dr. Helen Burney, and I've been working in sexual medicine with her for about 2 years now.
Awesome. And Ken Mitchell, hit it.
Hi, everybody. It's Ken Mitchell. I'm a physician assistant. I've been in men's health for about 27 years. Hard to believe it's been that long, but I'm in the great state of Arkansas in Little Rock, and I'm the clinical coordinator of men's health for the entire practice of Arkansas Urology.
Awesome. And he has more experience in this field than the three of us combined, and he's so dedicated. He is hopping on from his car. So thank you for joining us tonight. All right, I'll keep an eye on the chat box throughout the webinar. So if you want to share some thoughts or ask some questions, feel free to do so, and we can address those in real time. All right. So tonight we're going to hit some learning objectives. We're going to start with Helen. She's going to talk about relevant interview questions during that hiring process of an APP. Ken will outline the onboarding process of a new APP in a urology clinic, some actionable items that everyone can take heed from. I'll talk about relevant courses, written material, and societies that can assist with learning and networking, and also how we talk about continued training with regards to procedures after that official onboarding process. And then Christy will talk about what this continued training looks like when it comes to the importance of being in the operating room, whether or not that's going to be part of that person's practice afterwards, and what she's learned in terms of seeing various types of post-op patients throughout their healing process, as well as what her role is in terms of intermediate to long-term follow-up. So let's start with Helen talking about hiring.
So hiring, one of the most important things you can do when you're looking to bring an APP into your practice is to hire the right person, right? This needs to be someone that you see yourself getting along with, that you work well with as a team. And you want to make sure that your personalities mesh and make sure that they like talking about sex, right? So you want to hire the right person for you and your practice, because you also want retention, and you don't want to spend a significant amount of time training someone who's going to end up being unhappy in this field. We're all in this field because we love it, right? So we want to find other people that are going to love this and help promote men's health and sexual health. So, one of the ways to do this is to ask the right questions so that you can sort through who you feel is going to be a great match for you. What does the person like and want to talk about? If they loved a prior working experience of, being in an inpatient ICU setting or taking care of patients in a nursing home, maybe they're not going to enjoy an outpatient office setting of men's health or sexual medicine practice. Do they have a particular interest in sexual health? Do they feel comfortable speaking to patients about sexual health? Now, while we can always provide training and the resources and support to educate APPs on sexual health, it's very hard to change someone's preconceived built-in comfort level with discussing and talking about things that are so intimate and personal as sexual health. You know, we all come from different experiential backgrounds, different cultures, religions, and our own past experiences, right? And many of these things develop innate biases in us that we all bring to the table. And so it's important to find someone who's going to be comfortable normalizing sexual health with your patients, because we all see different types of patients and we all see different types of sexual relationships. And so having that comfort discussing sexual health with your patients so that they in turn are going to feel comfortable with you and open up to you about their issues and concerns is really critical. Do they cringe when you perform a sexual health history or perform a physical exam? You know, you want someone who's going to be comfortable performing a male GU exam. And there's a difference, again, between someone who maybe just hasn't done something like that before versus someone who can't imagine doing something like that. You know, you want to ask them, what does it mean to work at their highest level of licensure? And to do this, you need to be clear on the expectations of what you need for your practice so that you can see if their needs align with yours. Again, this is a team approach and you want to be happy and you want someone else that's joining your practice to be happy. You want to discuss and define the expectations, both for clinical care, procedural or OR involvement, as well as educational efforts and research. Do you want someone to help you in the clinic? Do you also want an APP to independently see patients as well? And which type of patients is he or she going to see with you or by themselves? Do you want them to independently practice? And do they want to independently practice and see their own patients? These are all important questions that you need to ask your applicants to see what it truly is that they're looking for in a job. And then that brings us to asking, you know, what does their ideal work week look like? Do they have a 5-day work week? Is it a 4-day work week? Longer days, shorter weekdays, longer hours, shorter weekdays? Do they want to work, less days a week? Do they have an admin day? And can you support that? Do they want to do procedures? Do they want to learn? Will you need them to do procedures in your office? You know, Christy helps me do Doppler ultrasounds. Christy does injection training. She does so many procedures in our office. So that was a role that was really important for me when I was looking. And will they be in the OR with you? And if so, do they want to learn that? Are they comfortable in the OR? What administrative tasks will they be doing? Are they checking the inbox? Are they replying to patient messages? Which patients did they respond to? Which ones are you responding to? And do they want to do research? So all of those things are really important in the ReLaView interview questions. And this just gives you a background, a little basic of idea of what to do. So we'll go to the next slide. And then you want to see, what are the qualities that you want in an applicant for a sexual health practice? Well, we all know we want someone excited about this field, right? Like, we love this. We want someone who really grabs the idea that we are the gatekeepers of men's health, and we're able to dramatically improve men's quality of life, even if they're coming into the room with ED. Have we looked at their hemoglobin A1C? Are they smokers? Do they have obstructive sleep apnea? There's so many ways that we can greatly improve men's health. So, many applicants love this aspect of sexual health practice. And it's something that I discuss at the interview because I want them to get involved. I want them to be excited and see the whole realm of what we can provide in a sexual health practice. You need someone who has good communication and listening skills to be able to do this. You can see this, in a well thought out interview by doing it in person and having them shadow you. I think that's something really important because every interview applicant I've ever had, including Christy, I had them come shadow me. I had them come see me in the office with patients and talking to patients. And then we sat down and asked questions and talked about the needs that we discussed in the other slide. As you know, oftentimes we play that mental health provider hat for our patients. Oftentimes patients come in and they really just need someone to normalize the process for them or restore their confidence or even just provide education, right? So does this person seem like they'd be able to do that? Are they listening to you in the office? Are they paying attention? Are they asking questions? Did the patient just get out of a relationship? Is this their first relationship back with a new partner? Could that explain some of the issues going on? Are they able to really listen to patients so that you can get to the bottom of what's going on and treat them? You have a patient with ED and PE, premature ejaculation, which occurred first, right? We all know that if the ED occurred first, oftentimes when you treat the erectile dysfunction, it resolves the premature ejaculation. But you're not going to get to that if you don't ask the right questions and you don't listen to the patient's story. So, the ability to discuss many different options to treat patients. Again, much of this goes with their comfort level because we can teach them therapies we use. We can teach them pelvic floor physical therapy, off-label medications, sexual therapy, occupational therapists, and all the many different roles for on and off-label uses that we have to treat patients. But again, are they comfortable with that? Do they have good communication skills? Are they going to be a good listener that's comfortable discussing all of these things? Because remember, most of the time, your interviewee will not have prior experience in this field, right? So next slide. Another important thing to kind of go over is research. Is this a requirement for your position? Meaning, if so, that expectation needs to be made up front. So they're not, if they're not interested, you're not hiring someone who's going to hate writing papers or collecting data for you or presenting it worse, right? You want to be clear in the interview. Is this important? Engaging their interest in this role. Educate, next slide. Education is also another role that all of us play in the healthcare field, right? Especially in sexual health. So how do you and they envision educating? They're going to become, just like you, the experts in this field. They're going to have other APPs and providers reaching out to them for answers. And so they need help with it, right? So they have a role in also learning and becoming lifelong learners and being this expert, but then in helping teaching others how to manage these sexual health concerns. So there's numerous resources available for helping train and educate your APPs, which Amy's going to talk about later in this talk. And then, that role transitions to them now being the teacher. Do they envision teaching students, and do they want to? Christy has several nurse practitioner students that come and shadow her monthly, and she goes over male sexual health, which is entirely something that they get almost absolutely no exposure to. And so, I love this because she's helping garner interest, and then she's helping prepare those APPs for wherever they end up. So that now they have this in the back of their pocket and then their armamentarium to help treat men's health, know when to refer, and know a couple tool sets. So, we just want to emphasize the role of APPs in educating patients about their health, their lifestyle changes, post-op care, teaching them why does something happen so they understand what they need to do to prevent it. And this is really going to help drive your change and your progress for your patients. I'm super, super, super lucky that I have an NP, Christy, who absolutely loves teaching, and she's great at it. And she gets texts from all over our department. I mean, they don't even text me anymore. They text Christy to ask questions. And, hey, Christy, I have this patient on Clomid. This is what their most recent testosterone is. What should I do? And I love that because it shows that I picked the right person, which I know, and she's an excellent educator and she's become an expert in her field. So again, at the end of the day, it's really important to know what you need for your practice so that you can ask the right questions so that you can find the right APP for you and your practice to thrive. I'll pass it over.
Amazing. Anything else, Ken or Christy, that you want to add? Christy, when you were going through this interview process, were there any questions that were surprising? If someone had asked you, if Helen had asked you, do you want to talk about sex? Are you comfortable talking about sex? What do you think you would have said?
I mean, I definitely am comfortable talking about sex. And I was like, well, yeah. But I mean, honestly, sitting through, like she said, I shadowed, I came in, I saw exactly what she did. I listened to the questions and I'm thinking, oh my gosh, these are a lot of questions I've never thought about, and I wouldn't think to ask, so is it something that I really thought about? No, but could I see myself doing it and I'm comfortable doing so? Yeah. And I was like, absolutely, I can do this. But yeah, I mean, definitely beneficial to shadow ahead of time when you're hiring your APP to make sure that they are comfortable, because maybe everybody isn't with some of those questions, and they can be surprising when you're not used to hearing them.
That's an excellent point. So folks, write that down, take notes. Tip number 1 is when you're interviewing, have the applicant shadow you in clinic so they can understand, is that something I want to do in my own practice? And then there is no guessing. They understand what those conversations look like. Ken, anything you want to add there?
I think those are all excellent points. I think about it in my journey coming into this at a totally different era where nobody was talking about sex. And then that little blue pill came along, and then all of a sudden, wow, we all have to start talking about it and developing ways around that. So I agree wholeheartedly. This isn't a job that you find. I think it's a job that finds you, and it exposes a lot of things about yourself that you might not have been aware of, and it's an excellent way to really shine as a provider, to really take care of somebody, both their overall health and well-being, but just their quality of life. So it's one of those rare specialties where you're allowed to do that. All right, so I get to
All right,
keep
Ken,
going.
hit us with the onboarding.
All right, so um, as my little picture there shows, the common onboarding experience really for most APPs, as Helen mentioned, is we just don't get a lot of exposure experience. So a lot of the times what ends up happening is that there's sort of this OTJT approach that happens, and it can be very fragmented, non-sequential, and it's just indigestible. It's just too much information that you can really grasp and then apply to be an effective clinician. Next slide, please. And so, the challenges, overall really are, somewhat related to what I call the three biggest issues, and that's the value, the volume, and the velocity of patients that need to be seen. And there are different perspectives on that. So, as a provider, you're thinking more about the disease states and things of that nature. You're looking at outcomes that need to be achieved. Service lines are really something that the practice is more concerned about. But we start talking about numbers of patients and the ways that you can treat those patients, again, just so you can have a sense of value is very important. And the velocity is a very tenuous one because we all need to see patients at a rate that we can at least address the needs in an efficient manner. And at the same time, the practice looks at that more like, can you see patients at a rate that's affecting the bottom line in an appropriate fashion? Next slide. Thank you. So again, this is just a breakdown of those different, as I mentioned about the volume. And again, understanding that there really are two different perspectives on there. And this is always going to be a challenge for the practice, especially if the practice really hasn't established up front what the expectations are for the APP when it comes to volume. As I mentioned early on, when you have on-the-job training as your primary source of how you're taught how to perform as a clinician in men's health, volume can be a real challenge because you will be slow. We all were when we first started out and we were training. And so volume can make you appear to be less valuable to the practice. And it can be, again, very problematic challenge. Next slide, please. Velocity, again, going back to the same issues, the rate. So rate and volume go hand in hand, really. So the more you know, the more volume you can handle and the better and more efficient you can be as a practitioner. And again, these are more looked at as a financial piece when it comes to the practice as a whole. But for the provider, it really is about how efficient can I be at taking care and meeting the needs of my patients. Next slide, please. And then value, which I always say is probably the most important thing. Value comes from two different places, in my opinion. That's value as a provider. Do you feel valuable at what you're doing? Am I providing a valuable service to my patients? Do my patients perceive me as being valuable? And again, the practice, more often than not, and understandably so, has to look at you from a financial perspective about how valuable you are to that practice. Next slide. So I believe really wholeheartedly that knowledge is the key. So really to meet all three of those parameters, the more you know, the better off you'll be and the easier things will get and the more you take care of your patients. And so I was told this quote here that knowing something so well that you can play with it is really what makes your life feel valuable and good for the patients. And it shines when you really know something, you're creative in what you're doing and you really will be looking at many different solutions and feel empowered to do the best you can for your patients and seek more knowledge and again provide greater value to those patients. Next slide, please. So in doing all this in my journey, I thought about how things have evolved. When I first started out, there weren't a lot of APPs doing urology, let alone doing men's health. And it dawned on me that if all of us are getting this on the job training as our only way of learning, it really didn't mirror the way that we all learned, basically we were taught or where we were trained. And so I developed these 6 pillars of onboarding because I thought this would be the most important way to make anybody feel excited about going into anything, in particular in men's health, because it's for a lot of people uncharted waters. And so it eases that transition. It does help you foster, reaching goals. It helps you be a lifelong learner. Helps you be creative and innovative, which I think is essential to being an effective clinician. And then also, again, helping with your growth and development. And then make seamless integration because you're dealing with two different things. One, a very challenging area of medicine, and also the perception of a field of as far as clinicians go that need to be recognized as being an integral part of the team. Next slide, please. So what we did though is for these 6 pillars is that we just kind of wanted to put some structure around that. And so when we talk about transitions, basically is that familiarity with again receiving and understanding all the clinical information one has to know, and doing that in an organized sequence, which is just the way we were all trained. And so with that, it just feeds into achieving goals and encourages self-assessment. I always say the best, way of knowing if you're an effective clinician really is to start looking in the mirror more often than not. It will really help you know whether you're doing a good job or not. And then get feedback from your supervising physicians, your colleagues, and to help you establish benchmarks in this area. Next slide, please. There we go. Got an animation missing. So lifelong learning and creativity and innovation, again, are also very important. So again, we put some structure around that. And in our case, it was about journal reading clubs, things like that. Attending meetings, I think, is extremely important. And then from that, again, one can start looking at being more creative and innovative. I think it's funny. Sometimes I think of things that are might be out of the box, and I've shared them with Amy, and she always laughs. She says, "Wow, I can't believe you didn't think about that." And same with her. I mean, I heard about Lanatrosa makeup pads with a Restorex. I mean, these are things you think about, like, wow, you're walking through Walmart looking at makeup pads for whatever reason. All of a sudden, you say, "Wow, that would work really good for a traction device for somebody's penis." So that's how you know you're a men's health clinician. Next slide, please. You can keep going. There you go. And then again, growth and development, I think, and integration are very important. I think the evolution of an APP in a practice is extremely important because I believe there's some growth that comes with the practice as the APP grows and develops. And that makes integration very easy. Let's face it, in today's world, we all have to be team players. And so that integration, I think, is extremely important. So it has to be support from the practice and from your colleagues to make sure that you are again there and able to do this for these patients. Next slide. So we took a different approach, but it's an approach that we're all familiar with, and that's basically the basic steps to learning, and that is you want to introduce subjects, you want to reinforce subjects, and then you want to master them. And so again, in the subspecialty areas, in particular, since we're talking about men's health, is you want to introduce this. Shadowing is a great way to do it when you're first even just interviewing, but even after you get started, I think it's a very important part of that. Also, getting some didactic learning, good resources that one can read to get the basics and the fundamentals down to taking care of patients in the men's health space. Then you can follow that just like we all did. We had to hit the books, then we got to hit the clinics. So you do some supervised clinic time and in the OR, again, for exposure and to apply that knowledge that you've been reading about. And the mastery, just at that, at that point, you should feel comfortable, again, knowing it so well you can play with it that you can be independently doing some things or a lot of things, depending upon how your practice grows. Next slide, please. So I think the training team is mixed up of everybody. So the physicians, I think APPs have to mentor one another. I have UAPA up there, SUNA. All these places are great places where your APP colleagues are there and they can be a useful resource. I would say one of the greatest pleasures of my work and my career has been the ability to network and meet so many people over the years. And again, I've had a lot of physicians, same thing, giants in the field who took me under their wing, were willing to collaborate and teach me and make sure that I was growing and that I was an effective clinician for men's health. Next slide, please. And so I believe there should be a reasonable timeline. I think this is probably one of the biggest challenges I think everyone faces, particularly as a new hire. It's believed that somebody should be up and running. Typically, I've heard crazy things like 30 days. I've heard 60 days. That somebody should know everything they need to know in this very short period of time. But what I think is important to understand is that, and I point this out to practices and my physician colleagues, you spent years learning your craft. To think that we're going to learn that in a matter of months is just really, not only unfair, but when you just say it out loud, it just sounds silly when you think about it. And so, what I've looked at over the years, looking at my colleagues when they were hired in practices, is that we all have this period of credentialing, which I think oftentimes is people fly by the seat of their pants in this area, but I think that is a perfect opportunity to start doing more of the didactic training, getting some of those fundamentals in place, getting journal articles, getting books in place, teaching the APP the fundamentals. And then the next months following that, you do again the clinical, just like we were all trained in school. And then follow that by getting them into clinics, again, helping them feel they feel good about their skill sets, and then there is where they can start to shine and grow, and they're furthering their development. Next slide, please. And so this is just the onboarding blueprint strategy. I'm not going to read through all the steps there, but this is just kind of an overview here. But again, it just makes a more systematic approach to how you can bring somebody on board. And then both for the practice, the supervising physicians or collaborative physicians, as well as the APP, having some structure around that, again, does help you reach reasonable goals, and get you to be an active member of the team. Next slide. And so one of the things I think is extremely important, Helen touched on this, retention, boy, is a big deal. If anybody's ever heard me speak in the past, one of my biggest pet peeves is that somebody gets hired for a job, they are not really taught the job, and then because they don't appear to be valuable by whatever metric we're looking at, they get repurposed. And I think that is just one of the worst things that can happen to somebody. And so I think, effective onboarding will lead to retention of APPs. I believe it's one of the things that helped me a lot become a leader in my field, because I felt comfortable with the way that I was brought on and everything that I was learning, those that were willing to spend time and teach me. I think it empowers you to be an effective clinician. And again, workplace engagement is important, and workplace relationships obviously is key, especially we're talking about integration. Next slide, please. Again, these are just more. I'm not going to read through each one of these slides, but really, I can tell you the team that I'm on right now. One of the things I think is extremely fun about them, and Amy's met some of them. We genuinely work for one another and work for it with the goal of really taking care of our patients. And that's from the front desk to the person that comes in and cleans, who comes in as we're walking out the door. We spend a lot of time with one another. And again, that helps everybody feel valued and part of this team and this family. Next slide. Again, developing future leaders, I think, is extremely important. I'm at the end of my career. I tell people I'm rounded third headed home. I want to see others come behind me. I want to see them become the next leaders, the next chapter in this growth and evolution of our field. Next slide. And again, empowerment is extremely important. And I will say this for the physicians, again, I know there's a couple here on the panel, but for those that perhaps might be in the audience, I think this is one of the most important things for anybody, and that is empowerment. If you are empowered, then there's a mutual trust that gets developed, not just with the physician, but also with the practice as a whole. Because the actions of the APP are often going to be looked at one of two ways: whether that APP was a good APP, a good clinician, good at taking care of patients, and was the person in charge of supervising them, were they good at, again, supervising them and making sure that this person was a good clinician. If you can do that, then again, there's an amount of empowerment that comes there. And then, as Helen mentioned, then you become sort of a resource for the practice, recognizing your expertise and not just your degree. Okay, next slide. And again, workplace engagement, I've already touched on that already. So next slide, and then workplace relationships. Again, can't say that enough. Literally, I'll make you laugh. We have a thing that we say every day when everybody walks into our clinic, and it's real simple. It's everybody says, "Good morning, fam," and we always say that to one another, and that's how we start our day off every day. And it helps us really as a whole honor our commitment to our patients, have a commitment to one another, and see things through. The summary that I have here, they'll really simply understand. Just put some structure around your onboardings, particularly on the training and the clinical aspects of it. And believe me, at every step of the way, at every touch point for all the patients and all the people that work in your practice, there will be a seamless and welcome atmosphere for these patients, and help them remain engaged. I believe that's it from me. I hope. Thank you so much.
Thanks, Ken. So Helen and I are going to go back and forth here a little bit. So Helen, talk to me a little bit about your experience with Christy. Once you hired Christy, what did your onboarding process look like? And what did that training process look like? And then Christy, I want to hear from you too. Oh, you're on mute.
There we go. So, like I said, Christy was amazing in the interview. She came and she actually shadowed me 2 days. She wrote notes. I was like, I love this girl. I have to have her. And I remember when I called her and offered her the job, I was like, everyone wants you that you've interviewed with. I've already been told that by HR, but I hope you'll pick me because I would love to work with you in sexual health. So I was so happy. But so when Christy started, it was a little bit crazy at Indiana University because this was right in the middle of COVID. We weren't seeing a lot of patients in clinic. Everything had commenced to virtual visits. And so, at a minimum or maximum, we were seeing patients 1 to 2 days a week in the office. That was it. There was no ORs happening. So, her entire, I think, onboarding and training process was about 6 months. She started, and like I said, this would be maybe 1 or 2 times a week that she was having exposure to patients with me, either on virtual visits or in the office. But it started by shadowing. Slowly, we started coming back to have more normal clinics again and opening back the ORs. And I took every advantage of having her be with me for almost everything that she could possibly see. I even sent her just to get a little bit of basic background understanding, even though our practice is 100% men's health, so sexual medicine and infertility. I still thought it was important for her to understand a little bit of the basics of general urology because, right, we have guys come in with ED that also are complaining of LUTs, and so that she'd know what to do with a hematuria workup and what needed to happen. So I had her spend some time with my husband, who's a urologist in clinic, as well as one of our other senior amazing nurse practitioners who's in our practice, who does all general urology and urodynamics and everything with BPH. So this, I think, was helpful. After that, she would shadow me. I would come in and I would do physical exams, and then I'd have her do it. I'd say, is it okay if my nurse practitioner also sees what I'm talking about? So she could get comfortable seeing not only what's normal, but knowing what normal is. So then you know what's abnormal, right? Because she hadn't done tons of these exams initially. After that, she would ask me questions in between patients. She would take notes. We did a lot of didactic training. I gave her some things to read at home, whether it was guidelines or some templates that I had typed up for management of how I do testosterone or an algorithm for injection therapy training, how to increase dosing. After that, after about I think it was maybe the first 3 months, and Chrissy, you'll have to correct me if I'm wrong, she started seeing, after shadowing me entirely, then she started seeing patients on her own. So she would go in, and similar to how we do with residents, she would come in and present the patient to me. And then I would come in, we'd do a physical exam together, and we'd talk about a plan. And then we transitioned that after a time when she felt comfortable to then she did everything. She just came back to tell me about the patient, what her plan was. And I went in and said hi to them and waved, literally. I had her start writing notes so that I was able to provide feedback in real time about, here's what I would write, or, this is really important what he said. We want to make sure that we include this, or that they're not taking nitrites, nitroglycerin, things like that. And then after that, I think, I had her come to the OR with me several occasions. She actually first assisted me on several cases too, so that she understood when we were going over pre-op and post-op instructions with patients, what these surgeries entail. And it gave her a really good understanding for when she saw patients and they asked questions, she could help understand them and she felt empowered. So I think it's important too for, I had her hear like my talk tracks. What do I say to patients? And I told her, make it yours, whatever you like, you can steal and take, but make it sound like you and what you're comfortable with saying to patients, what's your spiel on ED or the penile implant. So I think she did a great job. And then I think the other important thing was the coding, the billing codes changed in this last year, right? We have all these new billing codes. So it was helpful to be able to go over notes with her about, if we're going to bill for a level 4 new patient, this is what has to be in, and these are the changes here. Because in our institution, nurses and APPs and PAs as well, they see their own patients. They have their own independent clinic like Christy does, and she's able to bill her own things. So it's really amazing. And I'll quit talking. I'll let Christy finish and kind of add her thoughts, but I cannot be more excited about how amazing she is. And She really hit the ground running. I left for maternity leave after those 6 months, and Christy was on her own.
Christy, talk to us about what you think was some of the most valuable time spent during that first 3 to 6 months. And perhaps also the value of being in some of the general urology clinics.
Definitely valuable having that experience right alongside her, like doing those physical exams, because that's not a general exam is not something that you get a lot of experience with when you're in nursing school, nurse practitioner school. And again, knowing what's normal or what the different variations of normal, or, oh, this is worrisome, or this is typically benign, nothing to worry about. So super valuable. Also shadowing and kind of gradually, like, just like she explained, like gradually easing myself into it. Started out by listening, then I started seeing some people, then I would present, and then, you just gradually kind of increase your involvement there. Speaking on the general urology, oh my gosh, that was so beneficial, because like Dr. Burney said, we do strictly male sexual health, but I mean, I have a patient just today that came in and said, oh, I wrote on my paper, I'm definitely having lots of frequency, and but without having that extra background, again, not my area of expertise or focus of learning when I was, becoming a nurse practitioner. So it was super valuable, at least just to have a little bit of a background. And then you also, I'm not an expert in all of that stuff, but I know the basics. At least I know what to get started, or, the workup to get started, and when to refer on to somebody else. But yeah, I think just the really getting that time in clinic and in the OR was the most important. It's a little different in a specialty versus, like a family practice or internal medicine, where you guys are all surgeons, you're not in the clinic 5 days a week. So being a provider that's a surgeon and hiring on an APP, you need to understand that it might take, like Ken said, a little bit longer than 30 days to train someone, because I'm not in the clinic with you 5 days a week, only seeing patients. Like Helen said, it's 1 or 2 days a week, and the rest of the time's OR time. So it might take a little longer in a specialty when you're working with a surgeon to kind of get that your footing with the clinic skills and that sort of thing. Does that make sense?
Yeah, no, that's awesome. Helen, when you were describing the whole onboarding training process, I mean, I feel like I needed to take it like a nap, because it's exhausting. Like it is a process to train someone. I am training my second advanced practice provider fellow, and it's exhausting. And it's also like, you don't want to offend the person, but you got to give feedback. You got to give feedback on notes and communication style. And this is how I would change that. And, this is why the recommendation that you made, actually, because they're a construction worker, they wouldn't be a good candidate for this different, intralesional injection. And so all those comments, making clear up front, I'm going to give you a lot of feedback. And when I go through the notes, either that evening or later in that week, as I go through notes, I'm going to send you a bunch of notes, and I don't necessarily need you to respond, but I have to send you the information, because if I don't tell you now, I will never tell you this information. And then all of us, even if it's, any, like an APP who gets referred by another provider and they're not setting that person up for success, it just gets annoying. And when we get annoyed by the people, that are referred to us, where we feel like they didn't get the appropriate workup or the notation isn't correct, that's on us. That's on us for not communicating that information. So the time to do it, is early on, and it takes time, and it's being upfront with, this has nothing to do with you as a clinician. I know you've never been taught this information. My job is to teach you. So being upfront about that is certainly critical. So I'm going to go into some of the recommended resources. As urologists, we oftentimes assume that our APPs it will be so obvious. Oh, of course they're going to hear about Widers. But then it's like, well, where would they have heard about that resource? Why would they have ever heard about that resource? We mentioned things like Campbell's and AUA. Again, that's not like something that people know about. We know about it because we spent 5 or 6 years in residency, but this stuff needs to be told to our advanced practice providers, who oftentimes are not going to be aware of these resources. But they also allow us to realize we don't have to teach our APPs everything they ever need to know. We just need to direct them to the great resources and then teach them whatever we can when we're in clinic in the operating room. So we listed some of these resources here, the Atlas of Office-Based Andrology Procedures. Ken wrote this manual of men's health specific for advanced practice providers, and then a pocket guide to urology. And part of this too, our APPs will probably have some professional funds, but if we have the books and they don't have professional funds, it's going to be actually providing these resources to our APPs for, for free or to allow them to borrow it. Additional resources here from the AUA. Helen, you utilized and directed Christy to the AUA guidelines and on the phone. And it's important that every time we give a recommendation, reinforcing to any of our learners, hey, this is based on the guidelines. This is where I'm going off the guidelines for this reason, but really directing people to practicing evidence-based medicine and making it convenient and either printing it out, in the office or having it on a smartphone or the computer. And then sure, absolutely. Directing people to various webinars, we don't have to be experts in everything, but directing people to those experts. And I send emails all the time with links to different webinars. We also have to be respectful of people's time. So, advanced practice providers, they, some people go into that field because they don't want to work the hours of, maybe like signing notes and going to webinars and doing research projects on Saturday and Sunday. And so we have to respect their time, but at least making these available so people know that these webinars exist. And then societies, I listed a whole bunch of the ones on here, not just AUA, not just SMSNA, but so many other societies that have overlap with each and every one of our practices. And everyone who does practices sexual health or men's health or female sexual health, we all have our different niche. And so I do a lot of BPH and men's health and a little bit of infertility, but that's not a big part of my practice. And Helen's practice is infertility and male sexual health. So certainly some overlap there, but all of these societies are going to have initiatives for advanced practice providers, and SMSNA is going to be the ones that's really, leading that charge in terms of supporting advanced practice providers. So whenever someone reaches out to me with some interest in men's health or sexual health, I give them the link to SMSNA, and I'm like, you have to sign up ASAP to start networking with other people and to get on these webinars. And then certainly society specific for advanced practice providers, we listed them here. Gynecology, Ken has this wonderful organization. Really his organization, the goal is to teach everyone on the team. So not just advanced practice providers, but MAs and nurses and, physicians, because obviously, we're all treating that same mutual patient. So in terms of this ongoing clinical training, I do a lot of procedures in my office, like Helen does. And it's always this thing, especially for us when we start out initially, is, okay, I'm going to do XIAFLEX and I have to learn how to do it first. And then when does that transition go where then our advanced practice provider is doing XIAFLEX? I strongly believe that so many of these procedures should be done by advanced practice providers, especially because we're not in clinic as often as other people. We might have clinic 1 or 2 days a week. So to try and fathom scheduling XIAFLEX injections where all of those patients have to come through a surgeon's clinic is just a disaster and does not lead to efficient care. And so like, for example, some of the words that I would use when I'm in clinic, and I'll do a few of them first, and I'll ask the APP who's with me, and I'll say, have you done this before? Have you seen it before? And oftentimes their initial response is going to be no. And so they watched it a couple times, and then I'll say, do you feel comfortable doing it? And so the first time that the APPs that I've trained have done cystoscopies have been with me on awake patients. I'm doing it on appropriate patients. I'll ask the APP that I'm working with before I've met the patient, hey, do you think this person would be cool with you doing the scope? And sometimes they say, you know what, Dr. Perlman, that patient is really anxious. I don't think so. And so I don't put that person in that situation. So I will do the scope and our APP will watch. But for most of the patients, they don't care. They just want someone who's kind and who is deliberate in terms of making this procedure as comfortable as possible doing the procedure. We've all seen patients where they say, I will never go back to that surgeon because that scope was so uncomfortable. And it really is not rocket science in terms of how to make a procedure comfortable. We just have to care about making it comfortable. And anybody can make it comfortable for our patient. Our MAs, our nurses, our NPs, our PAs can make it comfortable. So we, as surgeons, don't have to be doing all these things. And comfort is something we need to train our APPs how to maximize. But what I'll do for like cystos, for example, is I'll walk into the room and I'll say, Andrew's going to scope you today, and I'm going to stand right next to him, and I'm going to walk you through everything that we're seeing as we do it. So I'm taking the attention off of the advanced practice provider as they're doing the scope, and I'm talking to the patient and teaching them about their body as we're doing the scope. But then in real time, I'm also teaching the APP and giving them advice on how to change their skill. And again, as long as the patient is comfortable and we're optimizing comfort, the patients don't care who's doing the procedure. And this is the same thing when it comes to penile injection therapy, spermatic cord blocks. They watch a few, they do it, I hold the cord, and honestly, it is totally fine and patients are fine with it. But the important thing is that if we're in clinic and the patient sees us in clinic, and this is the first time they're doing it, we need to be in the room with our APPs to show them we're all part of the same team here. And my role in this team is to talk you through it. And Christy's role in the team, or Andrew's role on the team, is to do the procedure today. In terms of this ongoing clinical training, also this discussion of pre-op discussion. So we can't assume that any of our APPs know what these relevant discussions look like. And as Helen and Christy, were saying, you just have to watch it a few times, mirror it, and then make it your own. But managing the expectations, if I'm going to get scheduled for a penile implant, will my penis be shorter? Will my penis get longer? And so understanding how you answer all those frequently asked questions is critical. And then when you don't know the answer, you just acknowledge. Any of us, we all acknowledge this all the time. I had a patient recently ask me, can I use a penile constriction band when I get my penile implant? I told him, I don't know the answer to that. I'm going to post on Twitter and I'll let you know. And that's what I did. And I let him know. And he was perfectly fine with that response. And then in terms of, making clear reasons for specific questions, these all seem obvious. Why we would ask our patients in terms of past medical history, any history of diabetes, pelvic surgeries, blood thinners, Peyronie's, nicotine containing products. What is their support system? Do they have upcoming travel or a busy work season? But folks, these are the things that will either dictate whether our patient can undergo a procedure or not. Again, going back to that patient who was interested in XIAFLEX, he's a construction worker. He cannot take any time off of work and he lifts heavy. So there is no way that he can practically do XIAFLEX given his work schedule. But we were about to have him sign the benefits investigation to look into XIAFLEX. But, my APP didn't realize that activity restriction. And so that's why it got missed. So the next thing I need to do is tell him, look, this is the reason. It's not because he's not a good candidate. It's because I had to figure out what he does for a living and if he can take off work. So we have to not only train people, any of our trainees, what to ask, we have to tell them why we're asking that question. If we're scheduling someone for a penile implant, we have to ask, do you have any penile curvature? Because if we don't routinely do an artificial erection at the beginning of the case, we definitely want to do that at the beginning of the case. So all of these things are important. And if we're not aware of them, they can easily be showstoppers. COVID status, recent fever, upper respiratory infection, blood thinners, if they didn't know to hold their blood thinners, if they didn't know our blood thinner policy, whether or not we're okay with doing surgery on a patient if they're on 81, milligrams of aspirin, if they simply don't have a ride home. So these are questions that, perhaps our pre-op staff will ask, perhaps our MA will ask, but at the end of the day, it's actually all of our jobs to ask all of these nuanced questions. And it goes back to Helen and her talk about hiring. There are some people who want to check the boxes. There is nothing wrong with that. There is a role in healthcare for people who want to check the boxes and see a patient, make sure there's nothing serious going on, and then see the next patient. But when it comes to sexual health, this is not a checkbox game. This is not a task, finished game. This is, I want to sit down with this patient and ask them questions for the sake of understanding their concern. And those are two very different things. Christy, why don't you talk about your experience and the value of that intra-op and post-op experience?
Okay, great. So OR experience is a very important component of the onboarding and clinical training process. Whether the APP is going to be directly assisting the physician in the OR or solely be in the clinic, it is still valuable for that APP to get this experience because they will be seeing these patients in the pre-op and post-op period. Getting the opportunity to scrub in for common cases is going to help the APP understand how these procedures are performed, and then it's going to help them out when they're seeing these patients in the clinic. It helps when you're trying to explain procedures to your patients, when they're asking questions about their surgeries, and also just help understand the healing process and the different wounds that you see in the post-op period. For example, if an APP is seeing a patient that had an IPP placed 2 weeks ago for their post-op visit, and they come in and they're complaining of pain in the tip of the glands, well, having been in that surgery and understanding how that procedure is performed, well, a small needle is pushed through the tip of the glands when they're inserting that cylinder. Therefore, that could be the source of their pain or the small bruise or small wound that they may see. And that helps you when you're understanding their healing. It's also really important for APPs to get the opportunity when they're in the training period with their physician to see wounds and post-op patients in real time with their physician. It's going to give you the opportunity to ask questions, get feedback. Again, it's also going to give you that opportunity to see the different variations of normal or to be expected wound healing, as well as to learn what's abnormal and what's not expected, or a possible presentation or signs or symptoms that may warrant additional interventions. You can go to the next slide here. The other thing is the decision-making on follow-ups. When are we going to see these patients back? And this is another important aspect of the clinical training. And a lot of this can be done through experience in clinic with your physician and just during the training period and seeing when do they typically like to see patients back with various diagnoses, but not only just when, but why, and understanding why. How long are we going to let this patient try PDE5 inhibitors before we see him back? How long are we going to let someone try intracavernosal injections before we see him back? How soon is too soon? How long is too long? How often are we checking testosterone labs, and how are we managing the follow-up of these patients? Many physicians might have a typical timeline in which they like to see their patients back, and with time, the APP can mirror this as they learn this through their clinical training. It's also important to kind of understand and know that sometimes the follow-up timeline might vary, and it might be dependent based on the provider's schedule and accessibility and that sort of thing too. So to kind of keep in mind that things might be flexible. It's also important for APPs to understand that there's going to be times where some patients are going to warrant a visit with the physician, whether it's just a very complex or challenging case, or maybe the APP has seen a particular patient in clinic a couple times or a handful of times, and they just can't quite get their treatment or their management under control, and they just need that expertise help of the physician. It's okay, and sometimes it's needed to refer back to your physician and get that expertise help, but knowing when it's appropriate to do so and that it's okay.
Awesome. Thank you, Christy. And I want to touch on that intraoperative experience, because to me, it seems so obvious that anyone that we're training, if we expect them to counsel patients on pre and post, well, they must be intra-op at some point. But Ken, and maybe you might have this information, that is the rarity. I mean, I was able to do that with our APPs because I had a fellowship. So that fellowship allowed me to say, hey, I'm helping support this fellow's salary. And therefore, whenever I'm in the operating room, the fellow will be there with me in the operating room. And whenever I'm in clinic, they're going to be there too. But that is not typical onboarding, right?
No, I agree. It's not. And like I said, in my journey, there were so few APPs doing that. Like I said, the physicians that opened up their time in practice so I could go see surgeries. I mean, there were so many guys that are, considered giants in the field who were kind enough to just let me come to their operating room. So I saw everybody, guys, surgeries in New York. I went to California. I went to Florida. There were resources there for me to learn. I think, as you said, it is critical, especially for those post-op follow-ups early in your career, so you really understand what's going on with those patients. And as it was stated, knowing what's normal healing for these patients, but also recognizing when there's problems. I think is extremely important. And I'll tell you, when things are working right, if you got a good team with the physician APP, boy, you will catch more stuff early than you ever would have if either one of you were by yourself. So I think, no doubt, that is key for that. And I think if things really go well, if things evolve like they have for me in the past, is that you can actually provide valuable insight for the surgeon before someone goes to surgery. Anatomical issues, all kinds of things, any potential complications of that patient, I think are extremely important. So again, never enough eyes, right? So when the hands are laid on those patients in the operating rooms.
Yeah, absolutely. And, we don't have to train our APPs to do the surgery, and so they don't have to see 100, but it might be one TURP, and it might be one HoLEP, and it might be one Rezum and one TESI and one penile implant. And it's also nice, to show some of the complex cases so that people understand, oh, when this person comes in and they have more swelling than another person, why might that be? Oh, this was a 4-hour case because it was a prior aborted case. And that's why this is a little bit different. So there are so many things, especially in prosthetics, where detecting these subtle differences can be game changing in terms of outcomes. It's easy when a red hot scrotum with pus coming out comes into the clinic after an implant. But it's difficult when there's a little bit of wound separation and a little bit of pain 3 weeks that you feel like is a little bit more than normal, but the patient has type 1 diabetes, and sometimes those guys just have more pain. Those are those are obviously the more difficult scenarios there. That could be the difference between someone going to the OR for an explant and saying, why don't I see you back in a week and see how you're doing? When it comes to setting APPs up for success, we have to define the patients who will be seen by our APPs. If we allow our practice to do that, our APPs, especially when they're not trained in all of urology, are going to get burnt out. It is that simple. When our APPs, when they told me they were ready to start seeing patients, I said, Kyle, which patients do you want to see and how many is reasonable for you? And I was an advocate for the APP. When I said, look, Kyle is a really good communicator, and right now I want his max to be 15 patients in the template. And their response was, well, we have to get, specific permission because typically it's a minimum of 16. Do you want me to ask for permission? Yes, I absolutely do want you to ask for permission, because when he educates those 15 people in the way that he is awesome at, then I don't have to spend 30 minutes in the room, filling those gaps. It's done. The conversation was had and the patient is educated. So we have to ask our APPs, what patients do you feel comfortable saying? And then we have to advocate and communicate with the practice. These are the acceptable diagnoses. We don't want really complex recurrent UTI patients and ureteral stricture patients in our APPs clinics if that's not going to be their expertise. And then we have to define which patients are best suited for the physician. When I meet with my schedulers and they say, hey, Kyle pretty much has your entire template, which are patients when they call in that instead of sending them to Kyle, they should be sent to you. And my response is, for guys coming in, let's say specifically for surgery, or they had a complication elsewhere and they're coming for, let's say, a second opinion or an attempt at a redo operation, those patients should come to my clinic. Patients coming in with urethral stricture, because I can then schedule different procedures perhaps during that initial visit. But really everyone else, the low T, the ED, the Peyronie's, like I love when I ask our APPs which patients you want to see and they said scrotal pain. I was like, are you serious? But they want to see the scrotal pain. So, why not, right? And then being available. So, Helen and I have our phones on us. We are available. We never want to make anyone that we work with, any type of trainee, feel silly for asking the question. Every question is fair game. We've been doing this for 5-6 years. Nobody else that we're working with has been doing it for that period of time. And so we have to allow people that grace as they continue to learn. We got to introduce our APPs to other team members. We can never assume that anyone knows who to email or my chart for different questions. So what I was doing when I train people is I include the APP on all of those emails that I send out so they can see, how do I communicate with other members of my team? Who am I including on these emails? What is the message? Who am I asking for what? Because even if they're not directly involved in that scenario, or if we're not asking them to do something, they still can start getting a sense of whose role it is to do what. We have to invite our APPs to our own meetings. If we're meeting with researchers, other clinicians, help them build their own referral network so we don't have to be the gatekeeper for them then reaching out to anybody else. They can develop their own network and reach out to people on their own. And then finding opportunities for CV building. So whenever I do, an outreach event, I'm always like, whenever it's let's say a resident or an APP, hey, do you want to join on? Make sure to add that to your CV. We're all looking to build our CVs. There is absolutely nothing wrong with that. And different opportunities like these webinars are great opportunities to have our APPs help educate others with us. And then, as Helen mentioned, ask them what that looks like to work at their highest level. That's going to be different for everybody. When I was looking to hire our fellows, I made it clear, I want you to be a leader in men's health. I'm interested in training a leader, not a body, not a person to fill a job. I want you on the stage. I don't need to present everything. I want you on the webinar. I want you doing the research. And so if that's what you're interested in doing, then this is the spot for you. And if you find that that's perhaps not your goal, that's okay. You can still be an incredible APP. It's just, this might not be the position where either of us are going to excel. And with that comes respecting boundaries, understanding that our goals as physicians are not going to be the same as some of the goals of our APPs. And we have to ask about that and respect those boundaries and allowing them to brand themselves. And, anyone with expertise has this incredible ability to educate, communicate with others and brand. And so I would never say, Kyle's my APP. I say Kyle is a men's health specialist and he's a member of our team and we work together, and you're going to see him next time you come in. And if you have to see me at some point, it means there's a problem. Otherwise, Kyle's your guy and he's going to take care of you. So we each have our own pain. We each have our own conversations in medicine that we love talking about. We don't have to manage all the pain ourselves, but we do need to ask, what do you like to do? What do you like to do? What do you like to talk about? And by some miracle, when we ask those questions, actually every single patient will end up being seen by somebody who actually wants to see them. We don't have to be everything for everybody. We have this incredible team. Our team members are our APPs, our MAs, our nurses, our front desk staff, our secretaries. And they really allow us to help optimize the care of our mutual patients. It is 8:02. I'm going to check the chat box here. If there's anything else. Let's see here. Okay, I think we're good. Let's see, Christy, Helen, Ken, anything to add before we wrap it up?
No, I think you did a great job summarizing that, Amy. Again, guys, everyone here, we're available to you. If you have questions, this is going to be recorded so you can listen to it on the SMSMA website. And just remember, hire the right person, invest the time in training them. Be available to them. It is a labor of love. You have to be available to train them, to teach them, to be there and respect their time. You have to. You got to make them happy. Thanks for coming, everybody.
Awesome. Y'all have a good night.
All right, too. Thank you.
Thank you.